Good evening. Thank you so much. So we'll be here for about 3 more hours. Is that okay with everybody? It really is such a pleasure to be back here. I am so honored to be invited. I won the Lila Award a few years ago, and so I was in Miami, I think, when we last met. Before I get started, can I just ask, how many medical students do we have in the room? Okay, great. And how many residents do we have in the room? And then what, I know we have the faculty and professionals, but are there others that should be putting up their hands? All right, so I'm going to be talking, yes, oh yes, you put up your hand. Yes, we all should put up our hands. I wanted to talk a little about this topic of female genital cutting, but I know that we have different levels of understanding about this issue. And I'm going to give a very quick and brief background about it, and then getting towards what I'd really like your take-home message would be is advocacy. Because as health providers, we really should be advocating for our patients, we should be advocating for women, we should be advocating at every moment that we can, and I advocate for girls as well as women. So this road to recovery is actually this concept of how can you get a woman who's undergone FGC to be in this road of recovery, and how can we advocate for her so she ends up with a healthy life. You know, I never got, is it here? This one, there we go, the green light. So I have no financial disclosures. The background of female genital cutting is really understanding what the definition of it is. And the World Health Organization, along with UNICEF and UNFPA, came out with this statement that it's all procedures involving partial or total removal of the external female genitalia or other injury to the female genital organs, whether for cultural or non-therapeutic reasons. And the reason I like to give this explanation is that, in fact, here in the United States, we used to do things like that, and still in the United States, we still do these types of things, and I'll get into that in a few minutes. You're noticing probably that I use the term female genital cutting, FGC, but there's other terminology like female circumcision, female genital mutilation. What I tend to do is I like to use the terminology that my patients prefer, and the majority of my patients consider themselves having been circumcised or cut. But I find that when I go to Africa and work with the non-governmental organizations there, they prefer the term FGM, and I sort of got blasted by somebody who said, why do you use the term FGC? Well, I use the term FGC when I'm in the United States because I want to sort of desensationalize it, and remove that emotional charge of the word mutilation. And honestly, the majority of my patients don't consider themselves mutilated. If you talk to them, they would be highly offended that you even use that term. They'd say, mutilated? I'm not mutilated. I'm circumcised like my sister, like my mother, like my aunt, and my grandma. But when I'm in Africa, you better believe I use the term female genital mutilation. So it really depends on where you are and what terminology you need to use to move the agenda forward. I was just going to show you a little bit about where it's practiced, and the reason why is that I think that a lot of people will sort of say, oh yeah, that practice, that occurs in Africa. Well, actually the majority of Africans aren't cut, the majority of African women, and people will sometimes say, oh, that's a Muslim tradition. Well, actually the majority of Muslim women and girls are not cut. And that there are other countries where FGM, FGC is performed. Usually I have somebody from India will come to me and say, Dr. Nour, you blanked out India, but it's true, the majority of Indians are not cut, but there's a small tribe in the northwest part of India where they do undergo it. So here's a better slide on where it is performed in Africa and the prevalence. So I was born and brought up in Sudan and parts in Egypt as well. And you'll notice that the northern Sudanese, over 90% of them have undergone FGC. So I grew up, as a matter of fact, that my cousins, my friends, people around me had undergone FGC, and this was something that was very normal and naturally a part of their lives. So who's at risk in the United States? We're talking about immigrants and refugees who've moved to this country, who've undergone the procedure back home, and now are living with the long-term complications or just with no complications whatsoever. In 2000, there was a US census, and we looked at the numbers and basically took the prevalence of the country of origin and then determined how many girls and women are at risk, or have either undergone FGC or at risk. And at the African Women's Health Center, we calculated the number to be 227,000. Coming this year, the Population Reference Bureau recalculated the updated numbers, and it's double the amount, 500,000. So what does this number mean? And you may start seeing that in the media, people are talking about, oh, girls are undergoing vacation cutting, that there's so many girls who've undergone FGC in the United States. These numbers don't determine that. What it just basically says is if a girl has a mom or a dad from a particular country, she may be at risk for having undergone it. And so here you see sort of by country of origin, the majority of immigrants and refugees are Egyptian who are living in the United States, Ethiopian, Somali, Nigeria, etc. So one of the big things is people ask me, so why do parents do this to their daughters? This is so horrible and horrific and barbaric, etc. And I try to get to this sort of move beyond the why do they do it to why is it done as a culture? And the majority of times, if you spend time with people who've undergone FGC, it is a cultural tradition, it's a rite of passage. Mothers are very much participating in it. Fathers tend to really take a step back. And they basically say, we want to ensure marriageability. If my daughter is not cut or circumcised, she will never get married. So I need to continue this tradition. Much like, if you think about it, the majority of European men and boys are not circumcised. In the United States, the majority, as you know, of boys are circumcised. And if you ask, this is not a religious reason, why are you circumcising your boys? The majority of people will say, well, it's because dad wants, a boy to look like him. This is something that we've done in our family. A similar thought process, mind you, a lot more is removed when we're dealing with FGC. But then there's the preserving chastity. We do a lot of outreach into the communities, and they really, if you spend time with them, they'll say, oh, a girl who has been cut looks much cleaner and more aesthetically beautiful than one who hasn't been. So again, how our brain has been trained a certain way to think of what is beautiful. It improves fertility. There is this fallacy that if the clitoris touches the baby's head at the time of delivery, the baby will die. And when we spend time with immigrants and refugees in the community, we say, well, so why aren't all Americans dead? There's a moment where they're going, oh, that's a good point. So again, as the stories get passed down from generation to generation, if you're not questioning these stories, you will continue the behavior. It is a rite of passage. Girls are looking forward to the day they are circumcised. There are many times where you hear a girl has gone home crying and saying, my cousin got circumcised this summer, why aren't I going to be, why wasn't I circumcised? And this is back home in Africa. And religion, as I'd mentioned before, the majority of Muslims in this world haven't undergone female genital cutting, but it does cross socioeconomic barriers. It crosses different types of religions. So you'll find in a certain region of a country, Christians, Muslims, and for instance in Ethiopia, the Flasha Jews do cut their daughters. So it's more of a regional rather than a religious practice. And then hygiene, again, like I said, people think that it's cleaner if a girl has been circumcised. I take care of the women who've undergone the most severe form, which is the type 3, according to WHO. It's where the majority of the external genitalia has been removed, and then there's an actual stitching that occurs. And so there's an infibulated scar that covers the urethra and then part of the vagina. And in those cases, there's the thought, much like what we consider in the past of having, the father's stitch after a vaginal delivery, that the tighter a woman is closed, the much more, it enhances sexual pleasure for men. So this is a little bit of the background, the history, the reasons why this is performed. But I want to switch gears a little bit to what do I do with this when I take care of patients, and how do I help women who've undergone FGC. And so I'm targeting the medical students and the residents in the room, which is that as I mentioned, we're advocates for change. I give so many presentations about this, but I give presentations that span, you know, whether it's a medical student, whether it's high school, whether it's, you know, I've given congressional hearings, that I'm trying to advocate for what these women have undergone and what they are undergoing right now. And what they may be suffering at this moment may have nothing to do with the fact that they've undergone FGC, and rather they are suffering other things. So when you're trying to be an advocate for an issue, you need to know the issue and you need to know your objectives. What are you trying to accomplish? For example, today, I am hoping that when you leave the room, you'll have a better understanding about FGC, and maybe you'll have a little more compassion towards you know, the family members that do perform this, and maybe understand that it's not male domination over women, but that it's much more of a cultural and a societal tradition. And hopefully, when you see patients, you will give compassionate, culturally competent care. So that's my agenda for today. When you do have an issue, and many of you will have different issues, be passionate about it and don't stop. If you really care about how that something needs to change, you have to keep drilling. And I've been doing this for about 20 years plus, and it's my pet peeve when I find that a patient has been mismanaged, there has been judgment that has been given towards her by health providers, where there's really been bad outcomes because of this, then I haven't done my job. You need to understand the players. So female genital mutilation, I'm going to use that word now. People join this arena for many different reasons, and they have different agendas. Some want to sensationalize it, and it is a good media. You know, the media wants to talk about it. It seems like a good thing for them to write about. But it doesn't always help stop the practice. And so what ends up happening is that if you read something in the newspaper or hear something on TV about a particular situation, you may walk away going, man, those people, they just, well, look at what they're doing to their daughters. And I find that the media, I spend time trying to educate the media so that we don't walk away going, these people, them, those, why are they? You know, but rather, how can we also participate in this social change? What I tend to do is that there are, as I mentioned, different people with different agendas. I listen to the agendas. I need to understand what they're driving for. Why are they trying to move something forward? Do I agree with it? I create partnerships. I really do develop solid partnerships, and I identify my opponents. And there are a few out there who are pretending to try to change the practice, but in fact, they're just wanting recognition for their work. And so it becomes a personal agenda and not the agenda of trying to stop FGC. You always need to be flexible because this ground keeps shifting. There have been players that come in and then they leave. Those who've been in the political arena truly understand there's people who are going to move you forward and others are going to pull you behind. But I think the most important thing, if I can also say it, is if change does happen, be humble about it, because it may have nothing to do with because of any work that you've done. It may just have been, I think I heard this earlier on, somebody was knocking, you knock on the rock, and then suddenly that thousandth knock, and you happen to be there. It may have nothing to do with you, it just happened to be that the change occurred at that moment. So what do we do in the African Women's Health Center? Before I get to a little of that, let me cover some of the medical political environment in the United States, what we actually do, what is our growing concern, how does politics impact our ability to give care, research, and be advocates for change, and then I want to just end it with the fact that there is renewed energy about this. So the federal law in 1997 banned FGC in the United States. That meant no cutting, no nothing, no women or girls could no girls under the age of 18 could undergo FGC. Now I'm going to just add a little something that cosmetic surgery has never been mentioned in this law. And I know that you are probably aware that there are many 17, 16-year-old girls who undergo labioplasty, etc., because they don't feel like they fit in their bathing suit or their gymnastics, but that somehow doesn't get a part, it's not a part of this law. Yet if you read the law and look at exactly how it's stated, it should fall under this, because you could have a woman come, an African woman come to a doctor and say, well, I don't want you to cut her, but I just want a little nick or a piercing on the side. And the doctor would say, well, that's against the law because you know you're committing FGC. But you'll have an American woman who says, my daughter doesn't feel comfortable in her bikini, could you please remove part of her labia? And then the physician will have no problem doing that. Little interesting here. 1998, the Institute of Medicine, the AMA, and ACOG came out with statements opposing FGC. 2011, September 11th attack on the US, and that played a role with my patient population. And then 2003, the African Women's Health Center published the data that I'd mentioned before. 2010, are there any pediatricians in the room? No. So in 2010, the AAP policy came out, and I'll mention that, and then they had to withdraw their statement. They had placed a statement initially that said FGC wasn't so good, and then I'll sort of bring you through that. 2013, my center is in Boston, the marathon bombing, and how it impacted my patients. And then in 2014, there was an addendum to the law that basically stated that any girl no girl should be taken outside the country to undergo FGC and then be brought back in, and that extraterritorial component was added. And then, as I'd mentioned, that the updated stats came out this year. So what does the law state? In 1997, it basically said that any girl who had undergone under the age of 18 gets nicked, cut, or whatever, there's a fine, and then the parents get deported. Statements from IOM, et cetera, said that we need to promote awareness, involvement of the medical practitioner. It's improper and unethical. We need to support efforts within the United States and abroad. And there are other statements from other organizations. What I found interesting is that organizations make a lot of statements, but then they don't take it any step further. It seems like a nice idea to say, well, we're against it, but when I would go and sort of say, well, how can we help educate our refugee and immigrant population? How can we take it back home? It was pretty much, we have a statement and we don't agree with FGC. So the African Women's Health Center, we predominantly see Somalis, Ethiopians, and Sudanese. We do a lot of surgical treatment. I do reconstructive surgery on the external genitalia, medical treatment, and psychosocial therapy. But the approach is much more holistic. So one of the things I'd like to introduce to you is that many health providers think, oh, she's been cut, let's talk about FGC, or let's not talk about FGC. You know, it's one or the other. Oh, you've been, you know, you were circumcised, are you okay, is everything all right? And she's like, well, I came in because my throat hurts. And then they, oh, yes, but let's talk about it. So you've been circumcised, is there any problem with that? No, my throat really does hurt. Or you'll have the other part where is it a good intended, you know, well-intended health provider who'll say, I don't want to talk about this, and yet that may be an issue. So it's the discomfort or the too much comfort about the issue. Our team, we tend to approach it much more holistically as if she brings it up, I'm as a matter of fact, will say you've been cut, is a problem? No, it's not, let's move on to other things. And then I spent time educating, as I'd mentioned, health providers, immigrants and refugees, the media, et cetera, and working closely with the American College of OBGYN. And I've been very happy and fortunate to be participating with them to create guidelines on how obstetricians and gynecologists can step-by-step take care of women who've undergone FGC. So whether they're pregnant or whether it's their first gynecologic exam, there are really nice step-by-step process of that. And then we spent a lot of time doing reproductive health workshops, outreach, talking about, you know, you can see there's the fallopian tubes and the uterus, diabetes, hypertension, nutrition, storytelling, and we usually spend a lot of time doing the sort of the African storytelling on how we view health and how health is important to us, and of course FGC workshops. And then the clinical care. There's a lot of long-term complications that women with type 3, you know, the patients I mentioned with the infibrillated scars, and that's why we recommend defibrillation, which is a surgical management. And what we found is that women who've undergone defibrillation do very well post-op and do feel like their symptoms have resolved. And then some of the long-term medical complications are fairly simple for an obstetrician gynecologist to take care of. And this is one of those things where we ask the patients if they have any issues with that. So what's our major concern now? And I know I sort of flew through it because I don't see you, this is not really teaching you the medical issues, but what our concern these days is that I think health providers, despite the amount of education we've done, still lack the appropriate knowledge to provide adequate care to women with FGC. Either, as I'd mentioned, get distracted with FGC, or they don't address the patient's concerns herself. And then we've also noticed that there's actual health disparities. So women, just in general, we know that they have health disparities when it comes to care. But now you have a woman of color, and we already have determined that there's health disparities between people of color and not. And then now you have a woman who's a woman of color who speaks English as a second language or may not be speaking English at all and needs an interpreter. And now we've got several layers of health disparities that we're dealing with. And then we have the fact that she's undergone FGC and she's dealing with a health provider who that health provider, him or herself, doesn't know how to feel about this issue. So you can imagine the type of care that she may be getting when she walks into an emergency department or into a clinic. And we basically decrease the quality of care that this person can have. And what we sometimes do is we ignore the killer diseases because we're focusing on the wrong thing. And because of what we do, whether it's like sort of a wincing, oh, she's been cut, or this is an educational opportunity, let's bring the resident and the medical student and the nurse and everybody else in to take a look at this poor woman, we've blocked access to care in all of these different ways. And then I will mention that sometimes I find that health providers are too compassionate. And you're going to say, oh, Dr. Nour, which way do you want it? Too compassionate, not compassionate? No. And it is a fine line, but I will get to that in just a second. So let me give you three very, very simple stories. Nafisa, I've changed the name of the patient, went to the emergency department in New York City for abdominal pain. The physicians and the health providers were distracted by her infibrillated scar. Medical students, house officers, nurses were brought in, and Nafisa herself felt very humiliated. You can imagine she's in stirrups and suddenly people are walking in and she's very modest and she's, you know, who wants to be in that situation anyway, honestly? And she walked out. Her abdominal pain was never addressed. She was just said, forget it, I don't really, you know, I'll deal with it on my own. And she came to Boston. And at that point, we were able to just talk to her. What happened to you? Tell me, so you came from Somalia. Why did you come from Somalia? What happened in Somalia? And as we were getting the story before we even examined her, I knew she was circumcised, so I didn't even get to that point. We found out that she'd been gang raped during the war, and that there was death. She saw the death of her sister and lost her family. So take that story. Imagine her walking to the emergency department, knowing that she'd been gang raped, and then people are looking at her and focusing on a scar that is not even a part of the issue at that point. She did have PTSD, but it was not because she had undergone FGC. She had PTSD because of the war and the gang rape. And that was where I'm saying, you know, there was a lack of understanding by the health providers in her situation. We have Layla, again, her name has changed. She saw an obstetrician in our institution who saw her and said that noticed that she was infibrillated. She was pregnant in her first trimester, and the obstetrician immediately said, I don't think we could have a vaginal delivery in this situation. What we need to do is, I think you need to terminate this pregnancy, then we could defibrillate you, the opening up the scar, and then you can get pregnant, and then you can have a nice vaginal delivery. And Layla, who did not feel that this was right, it was against her religion, but didn't understand and had no social support from her community who could have educated her, agreed and terminated the pregnancy, which she has been living with, that regret. We then were able to bring her and the health provider together to sort of discuss what had happened, and they said, I'm not going to hold it against you, but please learn so that you don't do this to another patient. And then you have Samia, who also is pregnant. She's infibulated, and she was instructed that she needed a cesarean section for delivery. The difference with Layla is Samia from Layla is that she had social support, and her friends were like, that doctor doesn't know what they're doing. Go to another doctor, and sure enough, she did. So although that physician had lack of knowledge, she was able to head to an area where we could defibrillate her and have her have a nice vaginal delivery. So what's the take-home message on this situation is that health providers, we still need to educate health providers a lot more. We should have an FGC curriculum in the medical schools, in the nursing schools, in midwifery schools, and you should have FGC training in residency and internships. So I want to get to that sort of, is there such a thing as too much sensitivity, which is this cultural relativism. So the American Academy of Pediatrics sat together and they were starting to make this ethical discussion, so we circumcise boys, and if we can cut the prepuce foreskin off of boys, why can't we nick or, for cultural reasons, pierce anything in the external genitalia of girls if they requested it? And so they came out in 2010 with this statement that it might be more effective if federal and state laws enabled pediatricians to reach out to families by offering a ritual nick as a possible compromise to avoid greater harm. And this is where I say we're a little too sensitive here, because this is not where we wanted to go, right? This is so, we had fallen along this path. The refugee community was educated, the health providers were starting to get educated, and now you have this community, the pediatricians, saying, oh, maybe we could nick something, The problem is, of course, then the media, oh my gosh, they were very upset. Medical professions seems to have lost its moral compass. This is no more than an alteration than an ear piercing. Is that true? And the UN organizations also pretty much threw a fit. And the good news was that AAP retracted the statement. The AAP Board of Directors basically said they did not endorse the practice by offering a clitoral nick, and it's forbidden under federal law, and AAP does not recommend its members to do it, and it was never a recommendation. But if you just get to why that decision even got made, so I spoke to a couple of people who were on the committee. It was a bioethics committee. They were being very theoretical. If we can do this to boys, why shouldn't we do this to girls? It was very insular. And what I found very interesting is that they didn't take into account that this immigrant and refugee community had actually, over the last 15 or 20 years, really progressed to a state where they were not wanting to cut their daughters. They had never gone into the community to ask them, is this something you need? Do you really want this? And they never had anybody at the table. So as our prior speaker had said, speak up. Well, it's important for you to be invited to be at the table in order to speak up and say, this is not necessary. There was not a single African or culturally competent physician at the table while they were making these decisions. So some statements from medical organizations are ineffective in that they just say this is bad, and some others are effective but not necessarily in the direction we want. So being too sensitive is not good either. So my major concerns about my patients is that they're facing very much the same diseases that other Americans are: obesity, hypertension, diabetes, etc. And that truly there is a disparities in health. We found that there's a lower rate of mammograms and pap smears and vaccinations in our community because of this disparities. We've also found that what has happened with 9/11 and the marathon bombings has really impacted our patients, and that they feel unwelcome, invisible, and unheard. Many would say, I felt my concerns were dismissed because they came with a hijab or something. And in the end, what we're trying to do is advocate holistically for this patient. So going back to this road to recovery, the road to recovery is a holistic road. It's making sure that she, as she is living in the United States, is getting the best care, highest quality of care that she can possibly get in the United States. So the Girl Protection Act that was passed last year in 2014 has basically, as I'd mentioned, said no girl can be taken out of this country to undergo FGC. But there's been a mass confusion, and if any of you have read anything in the media, the New York Times wrote an article, I think the USA Today wrote an article, and basically it seemed like there was like 500,000 women and girls who've undergone FGC in the United States or being taken away on vacation cutting, and that's not the case. And that's the problem that we deal with when it comes to advocacy, is trying to tamponade all of these, you know, it is a moving terrain, but no, that's not true, and that's not true, and please can somebody come and give me the data that actually states that you have seen that the girl has undergone FGC in the United States or outside this country, and there hasn't been any of that yet. And people who have been pretty much advocating for this have used my website to state this. So you'll hear people saying, we heard that 227,000 women and girls have undergone FGC in the United States. And using the data that we've created to manipulate sort of a social outrage in the United States. And sure enough, there's, you know, President Obama got pulled in. He's saying this is no excuse and it's a barbaric tradition. And I was like, oh no, that's not what we really wanted. People who've been working in this issue we don't want to use these words. And we want to use the data correctly. But sometimes the treadmill goes and it moves too quickly, and so what we're trying to do is slow things down. So there is updated data. The Population Reference Bureau just published it. CDC is going to come out with their numbers, which are pretty similar. And again, we're going to try to use that data to educate people, to say that this is a prediction, this is an idea of what these girls could be at risk of, not that they've undergone the practice. And we've been working with NGOs and health professionals and civil societies as well, writing letters to federal support on FGC. So going back to this and ending my talk is, again, when you are thinking about taking on an issue and then it becomes an issue that you really care about, really understand it, understand the players, make sure you know who your opponents are, understand that the terrain is going to shift, be flexible, and in the end, if change happens, don't take credit for it, but be a part of the movement and celebrate it. Thank you.